With Hsiao, you mentioned dosing 40 milligrams a week, and then you go up to 80 milligrams weekly or bi-weekly?
Yeah, so in this case, the patient went to 80 milligrams weekly, and I have gone to 80 milligram weekly dosing. I mean, it's off-label. On label, it's either 40 milligrams weekly or 80 every 2 weeks. But some patients I found just need the higher dose. So I've done 80, and some of them are ones where they're like, actually, I felt like I did pretty good with that loading dose when it was like stronger, and then like since then I feel like it's been kind of waning. Another thing that's being looked into is therapeutic drug monitoring. So getting an adalimumab level, for example, the trough level, maybe like a day before they get their next injection, just to see like, are you at a therapeutic level? Is there autoantibody, like you could get an anti-adalimumab antibody, and if it's high, it could be that they've developed antibodies to it, and that's explaining why it's not working. So I think that's probably going to play a larger role down the line as well. Have you guys done the higher dose?
I will do dose escalation to 80 milligrams a week if they're failing after 3 months, and I think that should actually be our starting dose. However, insurance plans are practicing medicine without a license, so that's not going to happen. So I'm successful about 30% of the time with that escalation.
And the other thing I'll add is that typically with HS, patients aren't on a biologic alone. They might be on biologic and finasteride, spironolactone, metformin, antibiotics on and off, zinc, vitamin D. So, like we said, the goal, like the outcome right now is a high score 50, which is 50% better. Well, who wants to be 50% better? So you need other things to get beyond that 50% better. So it's kind of tough because psoriasis is so easy to treat now with these great biologics, and we're not there with HS yet, so it's still a challenge, and we're often adding things to the regimen. And then you can always back things down if they're doing better. You can start to kind of take away things, but it's not like psoriasis right now.
Great, another question.
So we know that there's definitely some component of metabolic disorder, you put it in there. It's a lot of these patients, you know, they have pain, they're very uncomfortable with how they're training. So exercise is hard for them, both psychologically and sometimes physically. Are there any types of exercise that you guys find are easier for these patients to adopt, or is there any data that, you know, weight training may be superior to cardio or something like that in terms of reducing some of this inflammation?
I don't think there's anything that we can get them to do, sadly, until we get them under control, until we reduce that pain, because that's why they're not exercising. And whatever they're going to do, they're going to have to deal with friction. So when they're finally getting to a point where they're feeling better, but they still sweat a lot, I treat a lot of hyperhidrosis, so I will ask them about glycopyrrolate. They want to use that, or Qbrexza, the tablet with glycopyrrolate. Also tell them about things like Glide. It's a friction-reducing roll-on for athletes, so that should help them eliminate some of that friction.
And there's not great studies for exercises, but we do have some survey study data about things that tend to make people flare. So the sweating can be a big part. So, and then the friction. So sometimes I often recommend yoga, but not hot yoga. So just regular yoga, because it's a lower impact activity and you can kind of move through and do what you're comfortable with. Swimming can be good, but swimming can also be very stressful if they're flared, because you might be exposing areas and kind of, if you're at a public pool. So swimming's not the best option for everybody, but it can be helpful. And then like lower impact, and telling people just start with anything you can do, like walking. It brings up another good point that fatigue can be a really big symptom of HS. So ask your patients about their fatigue, and luckily some of our treatments do help with the fatigue and people feel better. So to Barry's point, you gotta kind of get that inflammation out of the way so then they can start exercising.
As a point of practicality, I'd like to bring something out. When we were trying to decide what was the next step after Humira had failed, and the bulk of you chose Cosentyx versus infliximab, I'm in private practice, and I now have one medical assistant as our biologics czar. And that's how many patients I've got in all of these fights that I'm doing, and we've got to play the game. Insurance plans are now looking more favorably on infliximab because they've now had time for us beating our heads against the wall asking for infliximab. So they're going to approve that more readily than they're going to do Cosentyx. So even if there isn't an actual off-label list they're gonna act like there is. And from a practicality point of view, I would have picked infliximab because it's gonna be easier to get for them.
Yeah, that's a great question. Going back to, being able to exercise or not, I think we talk about the high score, 50 and 75 and 90, but I feel like a lot of it for me is when a patient is able to do something that they love to do and they can finally get back to that. So I think regaining function, whether that's like some form of exercise that they're able to do again, etc. I think it's nice for us to get to know our patients. What is it that they can't wait to do again, and sort of work with them to try to achieve their goals.
And it's another good plug for some of the patient organizations because they have tons of resources to help patients with that kind of thing. What exercises can I do? What clothes should I wear when I do exercises? So share HS Connect with all your patients, make sure that they can get there. There's tons of great info because as much as I can tell a patient, maybe yoga would help, patients connected to each other and talking about what's worked and what hasn't worked and what made them better or worse is way more powerful, helps to combat that isolation, also helps them to know what, like Barry said, there's hope. Other people have improved and done better. And it is a little bit of a double-edged sword because they're online, of course, there's always people who can mislead people. So that's why I like to refer them to HS Connect, Hope for HS, the organizations that I trust are putting out good information versus like Reddit. Reddit community is what it is.
I also just wanted to ask Brinley Brooks to please stand so that you guys can say hello. We have a booth for HS Connect and we work with her a lot. Fearless champion for HS and for the patient voice and making sure that all of us always put that front and center. And so, really grateful for our collaborations. And if you have any questions after for her too, she'll be here.
Where's your book available?
Oh, thanks for asking. So it's on Elsevier, it's also on Amazon. Yeah, and it's just a very comprehensive text on all things about HS, including special populations. We didn't talk as much about pediatric HS, right? It'd be really important to catch these cases early and also have peds derms comfortable with treating early, so. Great, thank you guys so much for your participation. Thank you.
Thank you very much.